Hey, good people. Hey, good people. How are you? My name is Raven Miller, and I am going to kick off the last session for the day. Have you all been having a good time at the conference? Yes. Have you learned something at the conference? All right. And so hopefully we're going to close out strong here today. So my name is Raven Miller, and I am the Vice President of Portfolio Strategy and Business Development for the cardiac rhythm business at Medtronic. My particular role is I lead the 10-year strategy that maps out our products, our technologies, our evidence, and our programs that create access for care. And I am here today because 3 of my 4 grandparents died to cardiovascular disease. And I want to make sure that that is not the story of anyone else who has to lose their grandparent early in life. And so with that, I am now going to introduce my esteemed panel. First up, we have Dr. Rimsky-Dennis. You all give it up for him. Dr. Dennis is currently an outgoing interventional and structural heart fellow at Johns Hopkins, and he is also an active member of the Association of Black Cardiologists. And so I want to pause and have Dr. Dennis introduce himself to you all and say a little bit about why he's here today.
Well, good afternoon, everyone. As Raven stated, my name is Rimsky-Dennis. I am an interventional cardiologist. I am also a structural cardiology fellow at the Johns Hopkins Hospital, Johns Hopkins University. And my passion with regard to, health disparities, began a long time ago, as a middle school student, when I saw, some of the disparate care that individuals in my family, were receiving, in South Florida. That further led me to pursue a master's in public health prior to attending medical school. And ultimately, here I am.
Oh, all right. So we're going to be excited to hear from you today. We also have on the stage Dr. John Wang. John is the Vice President for the U.S. Medical Disease Area for the Cardiovascular Division at Bristol Myers Squibb. John, if you could tell us a little bit about what you do and why you gave your time here today.
Sure. Thanks, Raven. And thank you for having us. I'm really happy to be here. So cardiologist by background, have been at BMS for about 2 years or so. And what we do is we interface between the company and a lot of the providers in the cardiovascular space. The reason I'm here, it's actually pretty personal. So my mother was one of very few women who graduated from Seoul Medical College in Korea. And at the time, it was occupied by the Japanese. And so she wanted a better life and came here to the States. But one thing that she wasn't told is that although this is the land of opportunity, you've got to factor in bias to where you can actually go. So what happened was she trained really hard, and I can get into all sorts of details, but she wasn't able to find a job here in the US. And so she and my father had to emigrate to Canada, and I was born in a small steel mill town in Northern Ontario. But I kind of pinch myself when I see myself here in Washington, D.C. now with Raven a little bit. But, it really sort of drove home to me how that is something that, and I just heard it from her day in, day out. And you feel powerless and frustrated. And so I'm here because I am not going to sit back and just let that happen to people.
Amen.
So happy to be here.
All right. And we invite amens from the audience as well. All right. So with that being said, we want to kick off the conversation by giving you all some statistics so you all can be grounded in what we're going to talk about here today. So as we look at the U.S. World News and Report, what they showed is that over the last year, cardiovascular disease is still the #1 killer of Americans, more than COVID, more than cancer, more than HIV. And so it is important that we have conversations around cardiovascular disease, not just the treatment, but also the prevention of it. And so I want to turn over here to my panelists for our opening question. So we all know that heart disease is a burden on the US population and the impact that it has on different patient populations, not only from the disease burden, but from the access to care. So Dr. Wang, I'd like to start with you first. If you could tell us a little bit of the statistics around these disparities that we see, I'd love for you to share.
Yeah, sure. So thanks for that. I think it's maybe well known, but, just to reiterate the facts, you've got certainly, and I'm just going to use women as one dimension of intersectionality, only because I think that one sort of cuts across all other dimensions as well. So, for example, with women, when you have diabetes, you are 50% more likely to end up with heart complications compared to, let's say, a man. And a female non-white is 50% more than that already. So it's like twofold. In addition, within that subsection of female non-white, Black females, for instance, have twice the rate of heart failure. And we all know about, I think, well, I'm sure that perhaps some of you know about the stroke belt in the South, about why it is that there's a higher incidence of stroke. And that's along a different dimension of intersectionality. So that's on the patient side of what actually happens to them. On the provider side, the facts are, at least in the life sciences, there's underrepresentation of a lot of these dimensions of intersectionality. It could be gender, it could be race, it could be geography, or zip code, or sexual orientation. And we're trying to make moves to improve that. But then there's also providers who are less comfortable managing people who have those characteristics. Like, for example, I think there was a recent survey that 20% of physicians, current trainees, you excluded, current trainees are uncomfortable and don't really know the issues at hand for people who suffer from disparities. And so you can imagine people who have not been trained recently, just how much further behind they are. So I think on both the provider and on the patient side, there are so many facts that lead us to believe that we have a lot to do.
Okay, Dr. Dennis, I'm going to have you weigh in as well.
Most certainly. We know that, again, cardiovascular disease is leading cause of death in the United States. But in addition to that, it's also the leading cause of morbidity, in the United States. Individuals are living a lower quality of life because of the disease burden that exists. When it comes to women, we know that women are 30%, African-American women rather, are 30% less likely to receive an ICD than their non-white counterparts, even after suffering their first sudden cardiac death event. Again, this is a disparity that has outcome impacts. We know that individuals who are Black, these individuals are less likely, 40% less likely to receive newer technologies, particularly those that are deemed to be more costly. We know that individuals who are deemed to be Black or considered Black on paper or documentation via medical records, these individuals are less likely to receive drug-eluting stents. In the modern area of drug-eluting stents, they're more likely to receive bare metal stents in comparison to their white counterparts. And as it pertains to structural cardiology, which is my area of expertise, there was a study that was done looking at TAVR, transcatheter aortic valve replacement, which is a revolutionary treatment modality for severe aortic stenosis, which has a 2-year 50% mortality, right? So again, over the last 20 years, TAVR has revolutionized the space with regard to aortic stenosis. And from 2010 to now, we see that African Americans still represent only 3.8% of recipients of TAVR. There was one study that looked at individuals who received TAVR from 2011 to 2016. Again, this is a life-saving therapy for severe aortic stenosis, which has a 50% mortality 2-year rate, right? And that study showed that over 70,000 individuals here in the United States, 95% of the individuals who are recipients of TAVR or transcatheter aortic valve replacements were white, and only 3.8% of those individuals in 2016 were Black. As we stand here now in 2023, that number remains at 3.8%. So there's a huge disparity within all aspects of cardiovascular disease, from electrophysiology, from heart failure, as Dr. Wayne stated earlier, to coronary artery disease, and as I just indicated, in the structural cardiology realm as well.
So I hope what the audience heard is twofold, that there are two different disparities that we're talking about. One is the disparity of disease burden. So just the prevalence of disease in certain populations. So African Americans, Asian Americans, indigenous people are more likely to develop heart failure, more likely to have a stroke, more likely to suffer from a myocardial infarction. And there's then disparity at the point of care, something around the point of access where there's some sort of barrier before patients are able to actually access. So you put those two things together and it creates exacerbation on those that need to access care. Let me maybe put a story on this to make this real. So I have a colleague who is from the rural South, and she and her friends moved away after they graduated high school because they said, we don't want to grow up here. People after the age of 50 have their legs cut off. People after the age of 50 have their legs cut off. Essentially, what they were finding is that there was a high prevalence of diabetes and a high prevalence of peripheral artery disease that went untreated. And a lot of that came because the disease burden is higher in that African American population, and the access to care in those rural communities was also a barrier because they didn't have subspecialty care to be able to really help to manage their disease. Think about a 5-year-old not wanting to grow up in their own hometown because they are afraid their leg is going to get cut off. This is what we mean by disparities of care, and this is why this work is so important. Amen. So then the next natural question many of you all might be asking is, well, why do these disparities exist, right? And so that's what I'm going to now pose back to you all again is, what are some of the reasons why these disparities exist? So I'll start with you this time, Dr. Dennis.
So thank you for that question, Raven. You actually reminded me of another patient story that happened 2 years ago, actually. You know, as a general cardiology fellow at Johns Hopkins, you know, I was on my cardiac catheterization rotation, and there was an individual who had come in with a non-ST elevation myocardial infarction, which is simply a heart attack where, you know, he had elevated cardiac biomarkers suggestive of some heart tissue damage. That being said, he was scheduled for a coronary angiography, which is a bread and butter test that I do as an interventional cardiologist every day. But at this time, during my training, the attending physician or the physician who was overseeing the service decided that this patient would not receive the coronary angiography, which is a class, which he had a class 1 indication to receive. And again, I'm on the service and I try to be a good fellow. I try to be a good steward of health, and I try to be a good, you know, participant with regard to medical care. But I wanted to do some further investigation to see why this individual was being denied, you know, this coronary angiography. And lo and behold, after having, you know, a conversation, you know, with my attending, he had stated to me that, you know, the patient was not compliant. He had stated that the patient was non-adherent to prior medical regimens that were requested or that were ordered for him. He had stated that the patient, you know, would not be able to receive or adhere to the medical regimen should he receive a stent, you know, in the cardiac catheterization laboratory. And for these reasons, you know, he would not proceed with the procedure. So I went and I had a conversation with the patient for 15 minutes, and everything that was documented in the medical record and everything that my attending, my senior cardiologist, had stated to me about this patient was completely false. He indeed knew his medical history. He knew the names of all his physicians, including his primary care doctor, and the addresses of those facilities. He knew how to access the care with regard to transportation. He knew the names of all of his medications, including, you know, the dosages and how to take those medications, which is, you know, by far something remarkable amongst, you know, most patients, you know, if not many. And, you know, he seemed to me to be a compliant patient, and he was Black. So other than being Black or being someone who lived in a marginalized area or someone who lived in an underserved area, I could see no clinical or no medical reason as to why this individual should not receive that coronary angiography. So I went back to my senior attending and had a robust conversation about, you know, this procedure.
He said robust conversation.
And I stated all the things that I shared with you all with regard to what I thought about this patient. How I thought he was a compliant patient. He would be someone who would certainly adhere to the medical regimen should he receive a stent. And, you know, I had to advocate for him to my attending. And nonetheless, he received that coronary angiography that day. He was found to have 99% critical LAD, or left anterior descending artery stenosis. He ended up receiving rotablator therapy that day, breaking up the calcium and the plaque around that area, and he ultimately ended up receiving 3 drug-eluting stents. He went home, he got proper guideline-directed therapy, and he's still doing well today. I actually followed up with him in my cardiology clinic several times as a general cardiology fellow. So to answer your question, I had to throw that story in. There are multiple factors and multiple issues that I believe come into play with regard to why access to care is such an issue and why these health disparities continue to exist. But I think that we need to continue to serve as advocates for our patients on all levels. And we need to continue to have these conversations to make sure that this message isn't lost amongst us, but also amongst individuals in our communities.
Yeah, thank you for that. Dr. Wang.
Wow, I would have loved to have a bag of popcorn and just watch that robust conversation. That would have been fun. I would have loved that. Yeah, so, I break it down into 2 parts. One is, I think I mentioned this, patients and then providers. So on the patient side, and again, I'm just going to use gender as one of the dimensions of intersectionality. You have social expectations around, for example, and it's really around access. So it's around expectations for childcare, the kinds of occupations that people might be afforded, which then doesn't allow them cross coverage, or because of the occupations that they have basically inadequate insurance to provide for that care. And so they can't really access the care that they need. And so I think that's one piece that's sort of structurally built in. The other piece on the provider side is that the training, as I mentioned, they're not as familiar. What happens is, and let's just take chest pain, for example. So that's typically the male symptom of a heart attack or an impending heart attack. And women oftentimes don't have that symptomatology. They have shortness of breath. They may end up with back pain. They'll have what are called atypical symptoms. Now, I'm just going to stop right there. The fact that it's called atypical immediately says that there's a problem, because we're thinking, oh, it must be lower down on the differential diagnosis hierarchy. And that right there in the language even, there's a problem, right? So then you got down, so there's just that, the recognition of it. Sometimes it's even just ignored. You have people just sort of ignoring the diagnosis and saying, oh, it must be in the head, or supratentorial, as it's called in the medical field, and it's just dismissed. And then even when they do get diagnosed and managed, they're not getting, exactly to your point, they're not getting the guideline-based treatments. So, and that's on the provider side, right? So I think it's exactly to your point, it's this combination on both sides. And so the problem is big. And I think that those are the 2 drivers. We can talk a little bit more about maybe how we can go about addressing them.
Love it. So as you all can see, we're having church today, both on the atypical language not being atypical, and having robust conversations. Another point that I just want to raise is I do believe cultural competence is also key here. So when we look at much of the materials, we look at the reading levels of the average American is at the 6th grade level. It's at the 6th grade level. So as we're having conversations with our patients and we're saying you had a myocardial infarction, that doesn't always translate. And so we as providers have to be advocates for our patients and also make sure that we have appropriate translations. Another study that was recently published last year is known as GLIDE-HF. And what GLIDE-HF was able to uncover was using Optum data, so commercial data. And what it demonstrated was twofold. One was that patients who have been diagnosed with heart failure are not getting to subspecialty. So there is a statistically different percentage of patients who are white males relative to Asian females, Black women, Black men, Hispanic women, Hispanic men that are not even getting to subspecialty. And then when we get to the subspecialty, there is still a difference in the number of people who go on to receive the destination therapy. So statistical difference between white men and people of ethnic minorities, and between white men and people who identify as female. So from a point of care perspective, there's also still differences that we see. We've started to try to uncover some of those, and they range from implicit bias all the way to patients not understanding. So there are a myriad of things that we could address as you look at driving down inequities of care, which brings me to another question that I want to pose to you both. What is the long-term implication of us not addressing these, of putting our head down in the sand, of saying we've been talking about this for 20 years and things don't feel like they're moving as quickly as we like? What is the long-term implication of us not doing it? We'll start with you, Dr. Wang.
Yeah, so I think it falls into two buckets. One is obviously the outcomes of people. They are poorer. That's the worst thing on an individual basis. I think there were, though, some domino effects of that. So given the populations that we've been talking about, if, and again, I'm just going to use women as an example, if they have poor outcomes, health outcomes, it's well documented that they themselves certainly have, they're able to attain lower levels of education, of professional achievement. But actually for all the people that they care for, the same thing happens because they're obviously unhealthy and they're unable to sort of support those people who are dependent on them. And in our society, of course, it's mainly women who take care of most things, right? And so we're setting up really society to fail by not supporting the health appropriately. So that's one huge part, and that's absolutely the most important. And then second of all, we all know healthcare in the US is a profit-driven system. It's unfortunate, but it is sort of the system on some level. And so the costs go up because the outcomes are poor. They have more complications. And so it turns into a lose-lose situation. There's absolutely nothing good about it. And we'll talk a little bit more about how maybe as we think about how to change it, what the language and positioning should be to address that.
Yeah.
I couldn't agree with you more, Dr. Wang. I think the trickle-down effects of health disparities or inadequate care and health inequities are long, lasting and are, very detrimental as it pertains to that nuclear family. When you think about parents and you think about individuals who are charged with the task of, caring for children and individuals and their extended family and not being able to do so simply because of suboptimal health, you can think about how, vast, those issues span. Currently we spend over $200 billion in, this current healthcare system just for cardiovascular disease issues alone. And I believe if we don't continue or begin truly addressing these health disparities and health inequities in our current system, that number is only going to continue to balloon and morbidity is only going to continue to worsen, amongst individuals in underserved communities. I also think, that, there's much to be said with regard to the finances, that are being impacted, right? This is an unsustainable, number that we're looking at with regard to cardiovascular disease burden, the issues that it puts on the communities, the issue that it puts on the healthcare system, and the issues that it puts on, our government. So I think this is something that cannot be sustained. This is something that needs to be addressed sooner rather than later.
Yeah. If you want to build off of that, if you look at the U.S. Census data, we were just having conversations about data, right? In the previous conversation, and we were talking a bit about race and how people identify, et cetera. So for the current system, let me say that, for the current system, not the new one that our friend from Genentech proposed that we do, but for the current one, what it would suggest is that this is the first time since the census has been conducted that people who identify as white has gone down. And it went down by 9%. And people who identify as African American, Hispanic, and Asian all went up. What we initially had as projections for majority of country being Black, Brown, Indigenous, Asian, et cetera, was that it would be in 2050. That now is looking closer to 2040. So it's accelerating quickly. And so what I'm suggesting here is that if we don't think about how to open up access for people who are Black, who are brown, who are Asian, et cetera, we are going to exacerbate the problems that we have for the majority of the Americans that are accessing our healthcare system. Another piece I just want to call out is the social determinants of health have also been something that we've been talking a bit about, right, throughout the conference. So Dr. Wang, I'd like to come to you real quick and just, can you call out some of the social determinants of health, how they are related to cardiovascular as well?
Yeah, so there, I mean, I don't know if people saw the New York Times article about Dr. Geronimus, who had written a book about weathering, and she has just published, yeah. So it's now well established, right? But when she first published and did research on this, it was, she wasn't supported. Now I think everyone sort of has. Basically what it comes down to is discrimination adds stress to the body, which then leads to poor health outcomes. Hard stop. So if we want to talk about the main social determinant, we're talking about, and again, this gets back to where I am starting from, it's about bias. I mean, I don't know how else to say it.
Yeah.
Except it's just that thing. And we've just got to we've got to manage it. We have to hit it head on. How? I think because it's such a huge issue, right? I mean, there's so many facets to it. You know, we'll talk maybe a little bit later about how one might go about it. But I mean, fundamentally, it is a mindset and an awareness, because the brain obviously is programmed to fall into pattern recognition. And so that's the default. And, you know, we're better than just sort of defaulting to these sort of reflexive patterns. And we can use our brains to make our world better, like we have already done. But we have so much more to do. And I know that's a really high level, broad answer, but fundamentally to me, that's what it's all about. And so if we can keep all policies that are directed on that, just targeted on that, I think that's probably going to help solve a lot of the issues.
Okay. Anything you want to add?
The only thing I would add, to that, and those were great points, was some of the work that the Association of Black Cardiologists is doing in the area of addressing some of the social determinants of health issues in individuals who live in underserved communities. You know, one of the things that we're doing is trying to address some of the environmental constraints that individuals have. Because oftentimes we know that, someone can come to the hospital, they can receive the medication, they can receive the treatments, but if they go back into their communities and, they're plagued with a host of things in their environment that they can or may not be able to control, that's an issue. So, we've done a lot of work, in the Association of Black Cardiologists to help mitigate some of those environmental factors that exist. We've also did a lot of work and are continuing to do a lot of work to address some of the food desert issues that exist in these communities. We know that almost an estimated 80% of heart attacks and strokes are preventable. And many of these issues are caused by suboptimal care with regard to prevention, right? Individuals are not being screened. Individuals are not, taking the basic medications that they need to take. Individuals are not exercising. Individuals are eating, poor quality foods, which are ultimately, causing them to have suboptimal health. So addressing some of those food issues and teaching individuals how to eat properly, even though you don't live in a food-rich environment, it's challenging, but again, it's possible. Those are just some of the works or some of the things that us at the Association of Black Cardiologists have been able to do to see we can address some of those social determinants of health that exist, whereby we can ultimately break down some of these disparities that exist.
Love it. Maybe just ask a question to the audience. Has anyone ever been blamed for something that you didn't do? Anybody raise your hand? Anybody been blamed for something that you didn't do? How did you feel about it? Can I hear something? Mad, frustrated. I hear a sister up here like, right? You're upset about it. And in many ways, this is what we have done to Black and brown and female communities, is we have blamed them for things that the system has enacted on them. To have grocery store deserts and then blame people for not eating well is not acceptable. To have water that is priced so high relative to a sugary soda pop is going to make the decision for you. And so as we think about these social determinants of health, we have to think about who's really to blame here. Is it the people or is it the system that needs to be addressed? And so that's what we want to pivot to now. Are y'all ready to get to some solutions? Yes. So Dr. Puckrin said that in the first half of the NMQF, we were doing a lot of numeration, talking about the statistics, what's wrong. But he said there was a pivot around the 10-year mark where we started talking about solutions. And that's essentially what we want to start doing now, is talking about some of the solutions for how we address some of these disparities of care. So I'm going to go away from this language of disparity of care, and I'm going to start saying health equity. How do we raise health equity? And so, Dr. Wang, I'm going to start with you. So you work for Bristol-Myers Squibb, and I'm curious to hear some of the initiatives that you all have been driving to raise heart health equity.
Yeah, so we divide it into two. One is external and internal, and I'll start with the external stuff first. So we're working with professional societies like ABC, like HRS, which is the Heart Rhythm Society. This is a society for electrophysiologists who deal with the electrical rhythm of the heart. And atrial fibrillation, which is a very big risk factor for stroke, is something that we're helping them understand and surface where there are gaps in care. And we'll talk about this, how gaps in care actually oftentimes in quality overlap exactly with those who receive, those who are receiving are determined by social determinants are disparate in their access to care. So the two actually overlap. So that's one initiative. We're actually focused also specifically on organizations that are solely looking at advancing health equity. We have a campaign called No Time to Wait, NTTW. I don't know if you've seen it with Kareem Abdul-Jabbar for AFib. And he's a great spokesperson. He's extremely articulate. And he's actually participating and going into the community. So he's not just going to be on the big screen on TV, he'll be going to the communities to raise awareness. So not only in terms of quality care at the point of care, but also upstream to the patient side to have them advocate for themselves. And we've had some great patient stories where they've said, had I not seen that or had I not witnessed that commercial, I would have waited. And the thing about cardiovascular care is that waiting is really generally not a good thing when you have symptoms because things happen quickly, right? Stroke, heart attack, you kind of need to move quickly. It's a little bit different from other diseases that way. And so that speed to making an action is really important. So that's some of the stuff we're doing on the external side. And of course, we're funding a lot of initiatives as well around the research to better surface some of the facts, what's driving the disparity and the inequity in care. Then on the internal side, just in terms of our clinical studies, we're making sure that we have investigators and patients who are more diverse in our studies. That's super important because, I mean, honestly, how can you have a drug that is analyzed or been tested in an all-white male population and you're just kind of wondering, well, what is it going to look like in another population when it gets out into the real world? To your point, the demographic facts and profile of this country have changed so much, and we've just got to catch up to that. So that is a big focus. And really, the final thing is internally, a lot of it is just everything that we do is suffused with this diversity. So, for example, when there's a drug in the pipeline or an asset, even if we're thinking of acquiring it, we usually do some market research with expert physicians to get their assessment of, well, do you think this is going to work? I mean, is this going to be something that's worth sort of pushing to get to market? And what we're making sure is that we have diverse points of view. Yeah. And the reason for that is that forms the basis for our decision to move forward. And if we don't get that, what we call sort of the neurosocial diversity, then that is actually the market in which we're trying to have our drugs have impact on patients. So we need to get that in earlier. So on a day-to-day basis, we're actually incorporating that into our market research, into our understanding of what works and what doesn't work on the science. So yeah, it's on every level right now that we're trying to incorporate this lens.
Love it. Dr. Dennis.
Certainly. I think there's a host of different things that can be done, to address the issues of health inequity or health equity. That being said, one of the things that the Association of Black Cardiologists is doing is trying to increase advocates within healthcare and advocates on every level. And one of the ways that we are doing this is by supplementing and sponsoring the training for clinicians and individuals within medicine on all different levels. That means nurses, nurse practitioners, physician's assistants, internists, cardiologists. I mean, we are trying to sponsor and increase the number of individuals from diverse backgrounds as much as possible, because we believe that if if you have a diverse background, if you have a diverse workforce, those individuals will be able to, identify issues that may not be, seen and may not be addressed by, other individuals of different backgrounds. So one of the things that we're doing, again, is, supporting medical students as well. I recall when I was a medical student, at the University of Miami, which is, my home city, in a class of 156 students, there were 2 Black males, and I was one of them. That being said, the other individuals, although phenotypically Black, didn't identify with being Black, wasn't psychologically Black, but that's a conversation for another day. So, things were very challenging with regard to finding individuals who looked like me and could have, conversations with me about these issues. But again, I received support at that medical school level from the ABC and from other organizations, just to increase, again, the number of individuals in healthcare who come from diverse backgrounds. Because I believe, again, if you have those individuals who look like the patients, they are better served or in a position, to advocate a bit more effectively for those patients. And I think, ultimately the outcomes will be there.
Yeah, that's fantastic. Sound like you need to have another robust conversation, but I'm gonna leave that alone. So at Medtronic, we've done a few things as well. So I'll just mention a few. So on the hiring side, we've tried to make sure that we have diverse representation in both the pipeline talent and at the managerial level. So in the pipeline talent, what we've done is we've sponsored some interns from the Thurgood Marshall College Fund, which are recruiting primarily students from historically Black colleges and universities to come into our organization at the pipeline level. We're doing the same thing with SHIP, which is Society of Hispanic Professional Engineers, to bring those engineers in early to go through the pipeline. But there was a question that was raised yesterday by a sister from Pfizer, I believe, where she said, what are we doing to get people at the top? And I completely agree with her, because what we know about diverse leaders is that they hire a diverse workforce, right? And so if we want diverse workforces that are making strategic decisions at the table when the door is shut, we have to make sure that it is representative of the population as well. And so there's been some intentionality around who we are recruiting, how we are recruiting, to make sure that we are also advancing people internally. Second major piece we're working on is the placement of community health workers. So we've hired 3,000 community health workers globally to deploy all around the world. And they collectively have served over 1.2 million patients to date. What they have also done is not just talk to them about education, they've also done the work to connect them to a primary care physician. Why is that important? Because continuity of care is important. It gets at the opportunity to help with prevention before it comes to the development of diabetes, before we increase the risk of stroke, before we develop congestive heart failure. That continuity of care is so important. And then the last piece, we've also done a lot of work around the diversification for clinical trials, not just with the physicians, but also at the patient level. What we've learned is that patients are not being asked to be in clinical trials. Say it one more time. Patients are not being asked to participate in clinical trials. And oftentimes it is the diverse patients who are not being asked to serve in clinical trials. And so what we've learned is that if we ask patients, there's a high probability that they will say yes. And in fact, there was a study that demonstrated that African American patients and Asian patients were more likely to say yes to clinical trials relative to their white counterparts when they understood that the benefit would be for the long-term outcomes of patients who look like them. Because we are part of the village community. Correct. And what we do for one, we do for all. And because of that village mentality, if we educate diverse patients on the benefit of clinical trials, they therefore then participate. And so we've now worked with our clinical trial sites to actually go direct to patients through social media. So if you remember this little thing called COVID, anybody heard of that before? Right. So during COVID, we know that patients were afraid to go inside the hospital system, but we still had the clinical trials that were needing to be recruited for. And so it was through the social media outreach that we were able to recruit more diverse patients in all cities in order to really drive towards that goal. And so I think there's a new opportunity to empower patients even through clinical trials.
Sure.
So let me pivot a little bit and ask from a policy perspective, what is it that you are hopeful about and what do you think still needs to be done? So Dr. Dennis, I can start with you this time.
With regard to policy, I think, like Dr. Wang was alluding to earlier, I think, there needs to be more emphasis placed on these clinical trials and the representation of minority communities. Currently, I think the FDA has language that states that there should be a minority, that there should be representation across the board. But unfortunately, at the moment, there's no penalties for these researchers or researchers not meeting that particular, standard. I think there needs to be a standard. I think there needs to be, specific language that is placed for recipients of federal funding with regard to research and clinical trials. And if those parameters aren't met, then that funding should be, withdrawn. So from a policy standpoint, I think, that there's a host of things that the government can do to put more pressure on individuals to make sure that they have more individuals from diverse backgrounds represented in clinical trials. In addition to that, I think that from a policy standpoint, I think that we need to make the business case, right? Because again, we talked about how cardiovascular disease burden in and of itself costs over $200 billion, annually. And unfortunately, this number is not really, we're not really having the bang for our buck. We're not seeing, the outcomes that we'd like to see. So I truly believe from a policy standpoint, we need to make the business case that we need to target individuals from a preventative standpoint, whereby we can start seeing the bang for our buck with regard to these medical expenditures.
Awesome. Dr. Wang.
Yeah. Just going to echo a lot of stuff that Dennis and you, Raven, actually talked about, which is, diversity in clinical trials. Exactly to your point, like VMS is thinking about the outreach to make it easier. So, for example, travel is something that's hard for some patients. And so we're trying to set up and get the FDA around the policy idea to accept different ways in which we can collect data so that it is easier for the patient. It's not going to have the same audit trail as another study, but they've got to be willing to open up some additional degrees of freedom so that these patients can come into the study. So decentralized studies is what it's called. It's where we basically use the internet and the cell tower network to enable patients to do a lot of the participation from their home. And really allowing that, I think, is an important small little tactical detail, but it's really important to getting patients into studies. So that's a super specific example around policy. Dr. Ennis, you'd mentioned something about food. Exactly right. 80% of all cardiovascular and actually oncologic disease is actually preventable with appropriate food and exercise. And so this whole idea of food as medicine is something that really should be seen as the case, which really then begs for a policy point of view and position that it should be covered, it should be insurable, and it should be guaranteed. You would think that in a country that, has mobile phones in every pocket, that just paying for some fruit wouldn't be too far a reach. But I think that it is for some reason. And making sure that the food is of the right kind and accessible, exactly to your point, is super important. So that's a very big policy sort of objective, I think. The final one is just around bias. I mean, again, I hate to harp on it, but, if people can recognize the bias, have the policies in place so that it is written on paper, it is understood that certain things are unacceptable, and that you've got to demonstrate that there's no bias, I think that is in itself probably going to be a huge sea change in health outcomes. Now, again, there's so many different ways that that can manifest in policy, but it is sort of, I think, the guiding North Star for a lot of what we are trying to solve for.
Yeah, go ahead.
Certainly, Dr. Wayne, you made me think of another thing that I think, COVID has, revolutionized, and that's the use of remote patient monitoring and also telemedicine. And I think from a policy standpoint, being able to have those services that we provide the patient as it pertains to remote patient monitoring, having those services be reimbursable from Medicaid, Medicare, I think that would be huge. In the Mississippi Delta currently, particularly in those areas where, healthcare obviously there's some issues with regard to access. I know a lot of individuals over the past 2 years have been able to see their primary care doctor via telemedicine. They have taken advantage of remote patient monitoring, but unfortunately, many of those services are not being reimbursed from an insurance standpoint. So we can put policy language in that regard to make sure that these services are reimbursable. I think we can increase the number of individuals who are receiving adequate care, particularly in these remote areas.
Yeah, so I'm going to co-sign that and say I think Wi-Fi should be a right, not a privilege. How about that? To be a right and not a privilege. I also want to co-sign what you're saying about the implicit bias. So if you have not seen it, check out implicit.harvard.edu. If you have not checked it out, look at implicit.harvard.edu. There is an implicit bias test that anyone can take for free on multiple factors: race, gender, transgender, income, BMI, etc. Take it. You might surprise yourself. Why do I say that? Because I do think from a policy perspective, you can't measure you can't be accountable to what's not being measured.
Correct.
There's an opportunity, I believe, from a policy perspective for people to identify what biases are in the system and how can we then build strategies around them to really address that. I think that's an important part. Yeah. So as a last question before we open it up to the audience, I want to ask you all this. So I live in Minneapolis, Minnesota, is where I live. It snowed the day before I got on the plane, so I will call that out. But May 25th, 2020 is a day I will never forget. And that is the day that Brother George Floyd was murdered. And I'm saying that word, murdered. Okay. So on the backside of that, there was a lot of energy. There was a lot of enthusiasm around how do we drive more equity across multiple sectors, including health. And so what I want to ask you all is, how do we keep this momentum going? Because we're almost 3 years out. And I don't know if you all feel it or not, but is there fatigue you see in your systems around having these conversations? Any hands? Yes, seeing some fatigue, right? So I guess my question to you all is, how do we keep the momentum going? So Dr. Wang, I'll start with you.
Yeah, so it's a super important point. The incumbents is what I call them, the people who are in role, like you, all of us who are in position to make decisions and to take positions on issues. We need to make sure that we're activated. So that is our responsibility now. But then also the new generation, and actually I guess that would be you, Dr. Dennis, that are really motivated. We've got to bring them on fast. You've got to keep the supply of people who are focused on this really rich and deep, because this is a people issue. I mean, by definition. And so you need people who are really motivated to make sure that this is changed. I think that that is probably number one. Number two is, I think I talked about how you incorporate into your day-to-day work every time you make a decision, that this is the lens that you apply on it to make sure that you're eliminating the bias, that you're factoring it in, that you're making sure that you're getting that diverse point of view is super important. And then when you actually communicate it, so I think this is a big part of it, right? We all sort of communicate and understand things through language, in many ways, obviously visually and in other ways, but really through language. How you communicate it, both in the immediate term in our sentences, but also in campaigns, it's really important that that is capturing all the work that you're doing, both in terms of people capital and in terms of actual capital, that you're capturing it and relaying it so that people see that you are walking the talk. And I think when it comes to those two, when you fundamentally end up aligning those two, is when you're going to be able to maintain the focus, the energy, and really the idea generation around what it is that we need to do to fix this problem.
Mm-hmm. Yeah.
I agree wholeheartedly. I think, it is a people issue. I think to have conversations like this one. We need to continue to have these conversations and not just go back to our silos and remain silent. We need to take this information that we all learned from these conferences and conversations like this and pass that information on to individuals in our community. I think, that's one of the core ways that we continue the conversation and continue the message throughout underserved communities as it pertains to social determinants, so as it pertains to health disparities. In addition to that, those individuals who are the key stakeholders and some of the individuals who are, on the front line, I think those individuals need to receive more support from organizations like this and the ABC and a host of other organizations, because it is a tough task. It is a difficult job, so to speak. So I think support is something that is certainly necessary so those individuals are not fatigued and are not worn out in effort so that they can continue, to do the work that we so desperately need them to do. I think those are, some of the core things that we need to do to continue the message, continue the fight, so to speak, without, sounding too cliche. But again, I think we need to support those individuals and continue the conversation by disseminate this information within our communities.
Yeah.
Two things that I would say that we need to do.
Love that. So my addition to that would be to remain curious, keep asking these questions about why are things this way? Why are we having disparities? How do we change things? Keep asking those questions and then making sure that we then advocate for what it is that we're looking for. So I now want to open up the floor to questions that you might have. So
can I just add one thing?
Please.
So I think it helps when it becomes personal.
Amen.
It's like if you just really feel it, then that's sort of the engine that's going to make it go. Just to your point, the energy, that's a feeling. It's not some intellectual goal. It's the fact that you have an advocate and you see what happens when that advocate is not there because of whatever reason. And it's something that I think that we shouldn't really stand for, and it's that feeling I think that you want to sort of bottle up and have it available so that it gets you through those moments when you're invariably facing resistance, you're invariably facing fatigue. That's the secret sauce I think that each one of us needs to carry forward. Just wanted to.
No, I love that. Thank you. We'll start with this side of the room.
Hi, I'm Bakari. I work for NMQF's comms department.
I'm not sure we can hear you, Bakari, if you want to speak up.
Sorry. Can you hear me now?
Yeah.
Okay, perfect. Hi, I'm Bakari. I work for NMQF's comms department. And one of the things that I have seen throughout the conference is the idea of financial risk being prioritized over patient risk. It's one of NMQF's tenets. And I think that, a lot of the things that are at the core of these health disparities, to me, it seems like there's not a financial incentive for private companies to address them. The incentives just aren't there, and we can try to create them. But I think that, there's a degree to which the social safety net or, the things that would get healthy food, because food is medicine, or housing to people, they can't be, we've tried and failed many times over. And I think there's only a degree to which, private solutions or anything where the profit motive is, central, can, fundamentally address these solutions. So I'm wondering if, where you see the room to reduce, the profit motive or the focus on financial risk.
Yeah, I'll go first. So thanks for that. It's one of the dilemmas in the U.S. healthcare system because it is profit driven. So you're putting your finger on sort of the red hot button. This is just my point of view. And sometimes it's easier to work within the framework that you're given than try to blow it up and recreate it. Understand I'm a rebel at heart. And so I've had a lot of feedback about don't do that, don't blow things up. But, and so I would rather on some level emotionally, but I think that in terms of how to get there, what we're trying to do is understand how it is that we can frame the addressing of these biases and disparities as actually the best business decision that they can make. So a lot of it has to do with time frame. So yes, they'll spend a little bit more here, but long term, they will gain more than their fair share. Exactly to your point, Raven, about how the demographics of the country are shifting. So they will be left behind if they don't get up to speed now about their systems and their ways of working and their processes that address these barriers and these disparities. So I think it has a lot to do with how we communicate it and how compelling we are with our arguments. I don't know of another way because we've seen how hard it is to actually change healthcare from a government point of view. It's just really, really hard because it's so huge. What do they say? The U.S. healthcare system is the equivalent of the GDP of France.
Yeah.
And how quickly do things move in France?
Yeah.
Right. And then right. So it's going to take forever. So I think working within the system and somehow just making sure that they see the benefit may be the way forward for now, given what we have. I don't know.
Yeah. Bakari, I think it's a great question. And I guess I'll put on my MBA hat, at this moment. I think we've done a poor job at making that business argument as it pertains to the health disparities. I think we've tried to pull on individuals or stakeholders. We've tried to pull on their heartstrings, and we've tried to tug in that regard as opposed to tugging on their wallets, right? I think there's a huge segment of the population that's not receiving treatment, whether it be medications from pharmaceutical companies, whether it be PCSK9 inhibitors, or whether it be the newest valves, right, from Medtronic or from Edwards, right? There's a huge segment of the population that's simply not receiving the treatment or the care, and we haven't been able to effectively speak that language, speak that business language to those stakeholders, right? Because they're essentially losing out on this segment of the population. They're losing out on revenue. And I think that's a conversation that we, should continue to work on. And we haven't truly had, with the stakeholders or the powers that be within medicine. But I think that's a great point, because clearly what we're doing right now with regard to the numbers aren't working. I brought up structural heart disease as one example. From 2011 to 2016, only 3% of African Americans received a TAVR valve, right? And that's out of 70,000 individuals. From a market share standpoint or from a utilization standpoint, companies should be asking, why aren't more African Americans receiving this valve? And that's a conversation that I think we need to, have, and that's the conversation I think we need to do a better job at having. But great point.
Yeah. I would say maybe the last piece is, I think you'd be surprised at how quickly a business can morph if need be. So for instance, right, I'm dealing with patients who have heart failure and they're more advanced in their disease. But there's now a newer technology that we have or that is coming that helps with early diagnosis of disease and management of disease to try to help catch it before it becomes too advanced and they actually need the device that we have. So from a business model perspective, I think there's certainly room to morph and to shift, even as we look at preventative measures. And so as the policies continue to evolve, to really encourage that we have a wellness system, not a sickness system, that business models can morph in and shift as well. All right.
Hi, Camille from Acclinate. So I have a comment and a question attached to the comment, and it kind of piggybacks off of what Bakari just asked. So that was a great precursor. Thanks, Bakari. In terms of the clinical trial diversity. So, Dr. Dennis, you talked about the FDA recommendations. So the FDA, they put out a draft guidance last April about this time, requiring or recommending that companies put forth a diversity plan prior to pivotal phase 3 studies. And then in December, the PICT Act, there was law that was actually passed that put teeth behind it, saying, okay, now the FDA has the power to like enforce that. So there is, you know, legal backing behind it now. And a lot of companies are, you know, saying, oh my gosh, how do we now involve the community that we haven't involved before and get to these underrepresented populations? So with that in mind, I'd like to ask those of you on the panel who are in industry and maybe anybody in the room, we also just talked about incentives. And Dr. Dennis, you talked about like, there's no penalty, there's no maybe accountability or any penalty for not doing it. It's still new, right? So we don't know what ultimately is going to happen if companies don't meet these diversity goals or put forth these robust diversity plans. But I would love to hear from those who are in industry in the room, what types of incentives would you like to see, maybe from the FDA? Maybe it's a voucher. Maybe it's like, what would motivate folks beyond the fact that now it's law to actually do this and try to do it well and try to do it right and try to do it in a genuine way? I guess what incentives would like to fire, or also what penalties would like to fire? And have you guys gone to the FDA with that?
Raven, you want to go?
I can start first. So for us, I think one of the major incentives actually is just the learnings that come from it. So from a diverse perspective, right? If I look at the clinical trials of old, in particular on the heart failure side, from a device perspective, it's been roughly 20% at best female enrollment. Those are hard numbers. When you look at the prevalence of the disease state, it's 50-50, right? So there's a huge chasm between who's enrolled in the study versus who's actually from a disease state perspective. Once it becomes commercially available, there's difference. What we then also then see, to Dr. Dennis's point, is then chasms in those who then receive the device, because this is what your clinical trial is actually demonstrating. What we also know about the device is that from a health equity perspective, it actually performs better in women. So here it is, we have a device that performs better in women to help manage their heart failure, yet women are receiving that device less often. And so the learnings for us is, how do we work with our physicians to better position this as an opportunity to improve their quality of life, to potentially have life-saving benefits? So for us, I think the learning is, the incentive is, we're going to learn from it. How do we approach our patients that we know need these devices, to at least give them the opportunity to say yes or no? How do we empower them? And then how are the physicians then also learning to position this for their patients? Because again, what we've seen is that there's a chasm between women and ethnic minorities, even when they get to the subspecialists as well. So for us, the incentive is learning, especially knowing that there is a browning of the country that is fast coming. Right.
So I'm not in industry. I'm a solo practitioner, heading down to South Florida. But to answer your question, I think, if there were penalties, that were enforced, particularly as it pertains to organizations that receive federal funding for clinical trials, I think the penalty should, be to have those funds reduced either the following year, or have those funds, have to be returned if they don't meet certain quotas. I think there needs to be a hard set standard, a hard set quota, that certain numbers need to be met. And if those numbers aren't met, then you have to return a certain amount, again, of funds that were received by that entity. I think that the penalty has to be a financial one, because that's the language that most organizations understand.
Yeah, I'll just add to that. So the way we're thinking about it, it's really two sides of the same coin. So it comes down to the label, or the indication for use. And if our population is so narrow, then the indication will be narrow. And so we will lose out on that opportunity, because it won't be a broader indication, potentially, based off the population that we studied. So it's both on the same side of like, well, if you do it, here's your upside. If you don't do it, you're going to lose out. And so it really is one and the same. If they went ahead and did that, I think that would be a single solution to get people.
Thank you.
All right.
Yeah. Hey, so Joya Perry, OBGYN, founder and president of the National Birth Equity Collaborative. So Congresswoman Donna Christensen, helped write the Affordable Care Act. And while they were negotiating that, there were many of these conversations that we're currently having today. So part of the reason I love this conference, Gary and I work with the 40 under 40 leaders because there was, the FDA passed that under Barack. This is not a new law. And they said in this very room, we were in the old hotel, and they showed us each company and how many people were Black who had participated in a trial. And then we forget that we then had a person who was fascist to become the president. And a lot of the laws that we had under the ACA were taken away. So it might be back again. I'm happy to see that it's back again, but trust me, it's not new. We have been having conversations with the industry. Everything that y'all have been saying, I promise you, this is not new. What would be amazing is to figure out how to hold on to the energy, which is what you said earlier. How do we not lose the fact that we had the only person who was a physician in Congress was a Black woman. And she came to this meeting and put on this meeting for years. And so just really, I guess my question is, how do we not keep reinventing the wheel and starting over doing the same things and remembering that we did have a president who was trying to kill us? And so many of the laws that we had already passed, like on hospital conversion funds, what's happening with that? I mean, there's a bunch of them. The list goes on and on. So how do we really hold on to the equity that we did before? I'm right with that. Because you're right. I think, Dr. Niss, you had mentioned this. This is not new. Right? A lot of the stuff is not new. I think it comes down to culture. It comes down to, because you can't impose everything on everybody, but at least within corporate environments and organizations, there's a culture. And if it tends to be, if you incentivize people internally within your company to achieve X, and then you know what, that's the new baseline. Now you achieve Y, this is going to be the benefit you get. If you don't achieve that, then you're not going to see it. But there's got to be, I think, alignment around the incentive and the framework around these particular issues. So, for example, there was a trial, it was called Chief HF, and it was a decentralized study in heart failure. And it actually launched in March of 2020, which was right when the shutdown happened, COVID. And guess what? 49% Black. 49% in a heart failure study. The most before was like 15%, or it's like typically it's around 5 to 15%. It was remarkable because of the technology and the use and the ability, and also the marketing materials to make sure that they self-identified. That should be the new watermark. Yes. And then we should just go from there, because actually we live in a capitalist society. We do. So everything is about getting better, getting more. I don't think about a TV like, I mean, I want the thinner TV with the better color. I don't want to say, way back in the 1950s, it was a 300-pound TV with a tube this big on the back end. And, that's actually the standard, and anything better than that should be fine. And I think this idea of capitalism in the context of improvement and bias, that's actually what we need to do. So we're really good at capitalism in the strict sense. Can we apply it in every other dimension that can solve this? That I think is, and that's a cultural issue, I think. You need leaders, I think, who are in position to enforce that. I don't know what you guys think.
No, I completely agree. And I think it's persistence. So what I'd love to see is us continue to leverage the relationships that we all have, because we all identify with different folks and we have different stakeholders that we're engaging. But to use this as a forum to develop the message and then roll out the same message over and over again, I think is going to be key. I just realized that we're over time, friends, so I'm going to ask you all to come to the front and engage us.
Okay.
Oh, I can't.
Can I just give you a little hope? Okay. Just a little hope. I'll do it quickly. All Diversity in clinical trials, incentivizing biotech and pharma to move at every single level. It's already happening. So diversity plans mandated at phase 2 and 3, that's happening in all these companies. Your payers are already saying, if you are not representative, it's already happened. I'm not paying for it. Bang, bang, bang. For oncology trials, if it is not, I'm telling you, I know this is happening. So I don't know why nobody's talking about it, but in oncology trials, if it's not representative, you're not getting accelerated approval, which means you don't get to sell your drug as early as you thought, and you're not first in class, which is a big deal. It's a big deal. Everybody knows this. Devices are getting approved in Europe. It is not getting approved because the FDA, so let's give the FDA some credit, because it is not representative data from the US. It's already happening. So I can tell you, it's going to take this is not turnkey. So just because there's a diversity plan, it doesn't mean that it has great impact. So we need to get better and learn and share. but it's happening. Everybody. So for that, maintaining the momentum, I think you got a lot of people that are like, how are we going to get this right and be better? So I just, a little bit of hope.
No, appreciate it. All right. And so with that, I want to thank both of the panelists here for your time and for your engagement today. Thank you all for engaging us. I want to give a big shout out to the NMQF again for their 20 years of informing and inspiring us. And I want to thank you all for joining us, and we'll see you at the gala tonight. Thank you so much.